Introduction. Major causes of death in nursing homes. When one wonders what is the major cause of death in senility, the answer is not obvious. The statistics, however, reveal an important fact from the last decade. Malnutrition in nursing homes was calculated to be the cause of death, from a minimum of 4% to a maximum of 53% of the institutionalized elderly population, therefore, on average, about 1 in 3 patients. Although there is no precise relationship between the causes of malnutrition strictly related to the refusal of meals, and those divorced from it, we understand that lack of appetite represents one of the most important reasons for death in the community of the elderly. The malnutrition of the elderly can derive from causes independent of their will to eat, or which manifest themselves with refusal to eat. If, for the first problem, the resolution and compensation strategies are more predictable, as regards the lack of hunger, it is not always easy to have effective and prompt intervention procedures available. The importance of a method that individually investigates the causes of the refusal of food lies in the timeliness and clarity of the roles of the team members, and must propose rehabilitation programs to get the meal accepted, and to intervene on fasting in a structured way. The survey on the refusal of the meal of the institutionalized elderly analyzes the lack of appetite in geriatrics and its consequent phenomenon of malnutrition of the patient. This instrument was built with the aim of identifying the causes, which lead the patient who fasts, to a condition of risk of his own life. Finally, it proposes multiple compensation and resolution strategies for the problem. The investigation into the refusal of the meal of the institutionalized elderly is the premise of an individualized intervention plan, which will then be discussed in the team. The design of an intervention plan will be the natural consequence, which will have to consider the causes identified, the proposed procedures, and the resources of the facility in which the patient is hosted. 1.1. A definition of malnutrition. A definition of malnutrition is provided by the Ministry of Health. The document, called National Guidelines for Catering, defines this pathology as a condition of functional, structural, and developmental alteration of the organism. Malnutrition is a consequence of the imbalance between needs, income, and the use of nutrients. Malnutrition affects the quality of life and can cause death. There are 2 types of this pathology, which are malnutrition by excess and malnutrition by defect. Defect malnutrition is the one that most affects the elderly patient. This malnutrition manifests itself, in the patient, with weight loss, and can be a consequence of disorders in swallowing, digestion, and eating behavior. The undernutrition of the elderly has different percentages in the statistics, depending on the type of person, and involves up to 15% of outpatients, up to 60% of institutionalized subjects, and finally, up to 65% of hospitalized patients. In retirement homes, therefore, weight loss and malnutrition cause the death of 3 out of 5 elderly people. The refusal of food has a very important influence on this trend of the elderly population. 1.2. The most serious causes of inappetence. A patient can develop malnutrition for causes beyond his willingness to eat. In fact, the amount of food he takes may be insufficient, because pathologies and therapies can cause weight loss, or affect the absorption of nutrients. Even a drowsy state, which does not allow him to be awake, can lead to very little eating. The causes of malnutrition other than refusal to eat can be summarized as absorption deficit, neurological and muscular disorders, integrity of the organism. Finally, the level of assistance. Now let's see these causes in detail. Oncological or degenerative diseases of the systems. Tumors and degenerative diseases, which may require a greater nutritional intake, and at the same time reduce the patient's appetite. Organ dysfunction and removal. The dysfunction of the organs that take part in digestion, or their total removal, compromises the correct absorption of nutrients, with a consequent reduction in the caloric quantity. Interactions between drugs and nutrients. Some drugs can reduce, or even inhibit, the absorption of specific nutrients. Chronic diarrhea and vomiting. These events may involve the expulsion of undigested food material, or stimulate secretions to be expelled. Stroke, outcomes of intervention and pathologies, which make the functional aspect of the motor system serious. These events can lead to lack of autonomy, but above all to important dysphagia, since the patient needs careful evaluation and rehabilitation to have a real prognosis of the danger of suffocation. Drowsiness as a reaction to drugs. Side effects of some drugs, or overdosing, can cause drowsiness, which is to say, decreased alertness. In these cases, the guest will not feed, because he is unable to maintain attention. Advanced state of dementia, or vegetative state. The absence of vigilance does not allow natural feeding. The same is true for the final stages of some degenerative diseases, which lead to severe stiffness, such as Parkinson's. Frequent withdrawals and fasting for exams. Malnutrition can result from the loss of nutrients, due to frequent withdrawals and forced fasting, for example in preparation for medical examinations. Lack of assistance, or malnutrition at the entrance. Malnutrition may be a pre-existing condition when the patient enters the nursing home. In cases of poor or insufficient care, weight loss can be observed in the patient who does not receive the right care. Limited to these causes, there are several ways to intervene. It will be necessary to choose specific supplements and build a high-calorie diet, but only when appetite is low and a greater nutritional intake is required. A drug therapy plan will need to be built, or revisited, if malnutrition is a side effect. Finally, when the dysphagia is severe, and does not make rehabilitation possible, it will be necessary to evaluate artificial nutrition. We remember, however, that we must never take good care and care for the patient for granted, when he needs more time to eat his meal, or when he needs frequent and delayed meals during the day. 1.3. The borderline causes of loss of appetite. There are some causes of malnutrition, which can be considered hybrid. These eventualities are to be considered a borderline, i.e. on the border between the refusal of food and the causes divorced from it. We summarize them in three categories, which are the sanitary and pathological level, the therapeutic or pharmacological level, the level of care. Sanitary and pathological level. Poor absorption of nutrients, if it is linked to impaired organs of the digestive system, can cause weight loss. Malnutrition is not only a direct consequence of this, because calories are not absorbed, but there is also a feeling of malaise, which reduces hunger. When the cause of the malaise is resolved, there is a good chance that hunger will reappear. Examples of these discomforts can be compression of organs for ulcers, I.R.M.I.E masses, pain when chewing, swallowing and digesting. Other types of discomfort resulting from pressure sores, hemorrhoids and diverticular. Diarrhea, vomiting and constipation not only compromise the absorption of food, but create inappetence because of the pain they cause, and because of the discomfort they create. Therapeutic or pharmacological level. The damage that a drug can cause, in its side effects, causes malnutrition also because it can create a lowering of alertness. A patient who is not very awake during the day does not have enough time to eat a meal, and to drink enough. Care level. When the needs of a guest require a higher level of care, in relation to nutrition, it is necessary that a greater number of operators are dedicated to the patient. If assistance does not respect these needs, the calories and fluids administered to the patient will be insufficient. In addition to this, the elderly patient may become depressed and feel useless, resulting in less appetite. 1.4. The 40 causes of refusal of food in senility, rehabilitable. The refusal of food in the institutionalized elderly can be the consequence of various events. The causes that cause the refusal of food in the institutionalized elderly concern only fasting patients, provided they are not asleep. On the other hand, it is not correct to think that subjects in a vegetative state, in a coma, or who do not digest food for pathological causes refuse the meal. Let us now look at these causes, which are 40. The elderly patient eats less, for his old age. The elderly patient has a faster sense of satiety and fullness. That fatigue and that movement that make you hungry are missing. The elderly patient has difficulty in perceiving appetite. The patient does not accept the facility where he is hospitalized. The elderly patient has distrust of the caregiver. The elderly patient refuses food as a reflection of disapproval, because of his relatives. Meal times are insufficient compared to needs. The patient perceives unpleasant odors and visions. The diet is monotonous. The subject has sensory olfactory and gustatory disabilities. He feels the flavors less. The patient has dietary restrictions, for example due to diabetes, allergies, diarrhea, or diverticular. The dental prosthesis is incongruent, or the patient has no teeth and cannot chew. The taste or texture of the food has changed and is considered unpleasant by the elderly who must eat them. Chewing and swallowing require physical effort, but the elderly have little or reduced autonomy. The patient experiences pain when chewing, swallowing, or digesting. The elderly have intense pain, even in parts of the body that are not involved in digestion. The elderly patient suffers from chronic discomforts, such as constipation, diarrhea, or infections. The patient has organ compromise, or compression, due for example to ulcers, I.R.M.I.E masses, or tumors. The elderly may feel a sensation of crushing, or incoordination, caused by physical restraint. There may be communication deficits, such as aphasia, dysphonia, dysarthria, or deafness. There may be side effects, due to drug therapy, such as deep sleep. The elderly are subject to dizziness and disorientation when raised, complaining of dizziness, for example due to a pressure surge, or due to the internal structures of his ear. The elderly patient may have disturbances in orientation, caused by a change in the surrounding environment. The elderly can also suffer from serious disorders, caused by poor perception of time and memory. The dementia patient may not recognize food as food, confusing it with a game. The patient with neurological damage may forget the food in the mouth. The elderly patient has hallucinations that disturb him. He presents regression, he refuses food, as a child does out of spite. He always wants to go to the bathroom. He is wandering, he has a hard time staying still during the meal. He is afraid of choking on food if this has happened once before. He is sad that he has lost his home, and that he has lost his habits. He has lost self-esteem, he is mortified because he is fed. He is depressed, he no longer feels any kind of pleasure. He chooses to reject life, he wants to hasten his death. He has had anorexia nervosa, or a psychiatric illness in the past. He has drug withdrawal, either in the past, he was addicted to drugs, or he was an alcoholic. He reports feeling a knot in his throat, or he says he always feels nauseous. He has artificial nutrition, such as PG, but despite this, he cannot digest what is being introduced into his body. The collection of these causes, in the form of a questionnaire, was built in Italy in 2018. The acronym I.R.M.I.E stands for Investigation into the Refusal of Meals in the Institutionalized Elderly. At the American level, the acronym becomes I.R.M.I.E. 1.4. 2.1. Causes deriving from old age, and solutions. The elderly patient eats less, with age, due to physiological decay. In the elderly, lack of appetite can be a physiological event linked to general decay. Even without other complications, this condition can lead to refusal of a meal, and malnutrition. A more specific cause may be zinc deficiency, and the inhibition of the nerve centers of hunger, creating a condition of anorexia of aging. In the collaborating patient, it is possible to embark on a path that stimulates the appetite. Small and frequent meals can be offered throughout the day. Specific environments can be set up, such as a tea room or a summer kiosk, to stimulate appetite in a pleasant space. In the patient, on the other hand, who does not communicate effectively, or who does not collaborate, the solution becomes much more complex. In this case, the strategy of stimulation of mirror neurons by imitation is used. This procedure takes place by sharing the meal time with a caregiver, in a very quiet environment. The patient will imitate the gesture of eating, seeing the person in front of him do it. The patient has a faster sense of satiety and fullness. In the elderly, lack of appetite can be the consequence of a rapid sense of satiety and fullness. This event is determined by his previous eating habits, and by the reduction in stomach volume. The patient who collaborates can become a taster assistant, giving him a role that makes him feel important. This way you can still eat more than your main meals by snacking later in the day. For the patient who does not communicate and does not collaborate, mirror neurons are used, once again. That fatigue and that movement that make you hungry are missing. In the elderly, lack of appetite can result from a lack of fatigue and movement. The solution involves manual activities, which keep the guest busy. The patient has difficulty sensing appetite, and in the past ate small meals. The elderly who have consolidated the habit of eating small meals are particularly vulnerable to malnutrition. In fact, he may be discouraged by the difficulty of eating the whole meal, because it seems too abundant. It is recommended to respect his habits, using the buffet strategy, in which a dish with a few and various dishes is presented several times during the day. 2.2 Causes arising from the retirement home environment and solutions. The patient does not accept the structure and his elderly condition. When the elderly develop awareness of changes in their body, they may not accept the condition of assistance. The result is the loss of self-esteem and mortification, which can manifest itself in anger and aggression, or with the onset of a depressive state. In these cases, it is important to follow the patient at all stages of hospitalization, showing him the nursing home, when he is still in his home. Lunches outside the nursing home are also useful, with the nurse accompanying the patient to external bars and restaurants. The elderly have distrust of the caregiver. The patient can refuse the meal out of distrust of the caregiver, especially when the elderly person is blind, and when he is not used to physical contact. In these cases it is advisable to maintain a gentle approach, and to involve family members in the administration of the meal. Gradually the patient will also become familiar with the caregiver of the nursing home. The patient refuses food, due to the disapproval of his family. In the elderly who maintain memory and understanding, the behavior can easily be conditioned by family members, in whom they have particular trust. If the family member is distrustful of the nursing home, he may involuntarily pass it on to the patient hospitalized there, who could refuse food. To solve the problem, the team's goal will be to establish trust and collaboration in the family member. Meal times are insufficient compared to the needs of the elderly patient. The shortage of time dedicated to meals can be a cause of inappetence in the elderly, who can feel neglected, discouraged, depressed. In these cases, it is advisable to dedicate a greater number of professionals to look after the patient during meals, so that he can dedicate the time necessary to eat the food in peace. 3.1 Causes deriving from sensory perception and solutions. The elderly patient may perceive unpleasant odors or visions during the meal. Unpleasant stimuli, perceived in the place where the meal is consumed, can be a cause of inappetence. The elderly who know how to communicate this discomfort must be respected by changing their place in the dining room, with the aim of having a more pleasant environment. For the elderly who, on the other hand, cannot communicate, it is important to try a change of place in the dining room to check whether this is the cause of lack of appetite. The diet is monotonous. A non-varied diet, which does not stimulate appetite, can be a cause of refusal of meals in the institutionalized elderly. To solve the problem, it is important to research the foods that he likes best, so that he can offer these as an alternative. The purchase can be proposed directly to family members. The elderly feel less tastes and flavors. The elderly may feel the taste of food less. The causes can be various, such as side effect of drugs, long time in bed, finally, surgery. Even if, in most cases, this problem resolves itself spontaneously, it is important to follow the patient, offering him strong tastes. This strategy will also stimulate the recovery of his perception. The elderly patient has painful ailments, such as diarrhea, or complications of diabetes. The elderly may be forced to not be able to eat certain foods, due to problems such as diabetes, obesity, diverticular. He can have physical pain when these problems get complicated. It is therefore very important that his diet respects his clinical problems, but that it is also good, nutritious and pleasant. 3.2 Causes deriving from the oral feeding phase, and solutions. The dental prosthesis is incongruent, or the patient cannot chew. The elderly may have dentures that, over time, break, or are no longer stable. He can also lose his teeth, and be unable to chew food anymore. In these cases, a creamy meal, easier to chew, can be offered. Even more important is the construction of a new dental prosthesis, so that the elderly patient can continue to take a pleasant diet. The elderly refuses food that has a different consistency. The elderly, with dysphagia or greed, can refuse the meal if the consistency is unpleasant. In fact, in these cases, a creamy meal is often needed, which appears less good than the normal meal. If the elderly refuses this food, it is important to present dishes that are already homogeneous in their normal form, such as soft cheese, yogurt, pudding, jam. Chewing and swallowing require a lot of physical effort. The elderly can give up the task of feeding when the act of eating requires effort. In these cases, the speech therapist can initiate rehabilitation to strengthen the patient's autonomy. At the same time, the elderly can eat the dishes mentioned above, which can be chewed with the tongue but pleasant, such as mashed potatoes, meatloaf, or even soups. The patient feels pain when he is chewing, swallowing or digesting. When the elderly patient has pain in the mouth, throat or stomach, they can easily refuse food. It is mandatory to inform the doctor immediately so that he can prescribe a treatment. It is mandatory to see the doctor, even patients who have pain but do not communicate, because many times the refusal of food can cause pain in the teeth. 3.3 Causes deriving from digestion, and solutions. The elderly patient has intense pain in a part of the body that is not involved in digestion. The elderly can refuse food because they suffer from severe and very intense physical pain. The most frequent cases concern pressure sores and joint pains. In these cases, the fast usually ends when the pain subsides. For this reason, it is important to identify the origin of this pain and prescribe a cure. However, physical pain is unlikely to heal in a short time, especially when the skin is compromised by ulcers. It is therefore necessary to prescribe a diet that accelerates healing, and that brings a sufficient number of calories to the patient's body. Another solution can be the administration of analgesic drugs before a meal. The patient is suffering from chronic discomfort. Examples are constipation, nausea, diarrhea, and infections. In these cases, it is a good idea to monitor the amount of fluids the patient is drinking. The first step in rehabilitation is to make the patient drink a lot, because often the refusal of food derives from a condition of dehydration. One strategy to make soft drinks more pleasant is, for example, the proposal of different drinks than usual, colored with aromatic syrups. The patient has compressed or compromised organs due to, for example, tumors, air, or ulcers. When the stomach of the elderly is compressed by a mass, the organ has a reduced volume. The patient, therefore, has the sensation of being full, even when the stomach is empty. In these cases, it is necessary to propose to the elderly patient many meals during the day, as long as they are small, frequent, and very caloric. Even if the elderly report that he is not hungry, and stubbornly refuses to eat, the caregiver must offer the patient a small glass with the calories dissolved in a liquid, such as hot chocolate, and supplement. The elderly need to take the glass, as if it were medicine. Physical restraint compresses the abdomen of the elderly. When the doctor prescribes a restraint belt, the patient is forced to wear it. However, the restraint belt can compress the stomach, with the consequence described in the previous topic. In these cases, it is necessary to release physical restraint during the meal, with a caregiver always next to the elderly person, so that he is supervised and in a safe condition. 3.4 Causes deriving from physical decay, and solutions. The elderly may have language difficulties, and are unable to communicate. Communication disorders can be input, for example deafness, or output, such as dysphonia, dysarthria, or aphasia. The elderly, especially when suffering from dementia, can have many diseases that interfere with their ability to communicate. Refusal of food can be a manifestation of this malaise when the elderly gets angry or depressed. In these cases, the caregiver can use augmentative alternative communication tables, which use images to make the patient express the concepts, which he cannot explain with just his voice. Deep sleep can be a side effect of therapy. Very often the elderly who have physical pain, or who have aggressive behaviors caused by dementia, can have drug therapy to help them become calm. However, when this therapy makes him sleep for most of the day, the elderly do not have enough time to eat a meal. In these cases, the doctor must correct the treatment plan. Getting out of bed, or changing position, generates dizziness or disorientation in the elderly. Too often, a very important aspect of the elderly is neglected, which is their pressure, but above all the structure of their inner ear. The elderly patient, in fact, is particularly prone to vertigo and dizziness when he lifts his bust. To allow a correct posture during the meal, however, it is necessary that the torso is at 90 degrees, with respect to the legs, with the risk of generating this discomfort during the change of its position. It is always a good idea, therefore, to wait a few minutes after changing the posture of the elderly patient, and before administering his meal. The subject may have difficulty orienting himself in the space that surrounds him. The patient with dementia risks getting lost in the environment that surrounds him, and getting confused, because he is disoriented. For this patient, eating the meal will become an unpleasant event, because he does not recognize where he is, and does not feel safe. In these cases, it is advisable to have the patient have lunch in their own room, that is, in a familiar, quiet, and very peaceful environment. 4.1 Causes resulting from dementia, and solutions. When the elderly patient is disoriented over time, they have difficulty understanding their age. Doll therapy, used in dementia, has several benefits. This therapy consists in providing the elderly with a doll, which looks a lot like a newborn, so that the patient cuddles her, becoming calm. However, it may happen that the elderly refuse food, because they want the doll, that is, the one they believe to be a child, to eat first. In these cases, it is necessary for the team to plan differently the times in which to provide the doll to the patient, that is, away from meals. The dementia patient may have difficulty recognizing food as food. When this happens, it appears that the patient is a child. If the elderly person does not accept being fed, he should be allowed to play with food, even if he gets dirty, and even if he uses his hands. In this way, just like a child, he will want to explore the object with his mouth, coming to eat it. The elderly forget the bolus in the mouth, due to dementia. When short-term memory is impaired, the elderly can forget that they have put food in their mouth within seconds. The patient does not swallow the object he has in his mouth, because he confuses it with his tongue, or with other organs of the oral cavity. In these cases, it is recommended to use cold foods. The low temperature, in fact, stimulates swallowing, and a cold object is not easily confused with the tongue, also becoming a memory feedback. The elderly have hallucinations that disturb them. In particular types of dementia, the patient may feel persecuted, becoming paranoid. Often he refuses food because he imagines that the food is poisoned. One solution is to provide packaged foods, which the patient can unwrap with their own hands. These dishes will be eaten, together with a caregiver, as proof that the food is edible. 4.2 Causes deriving from cognitive impairment, and solutions. The elderly can regress to a child status. A behavior of the patient can be the refusal of food, as a spite, or as a childish pattern. The caregiver will have to apply strategies, just as if he had a small child in front of him. For example, the patient will be fed with kindness, playing, or offering sweet and pleasant dishes. If the elderly has regressed, the infant sucking reflex may reappear. This event is an advantage, because it allows the subject to drink easily with a straw and caloric liquids. If the elderly always want to go to the bathroom, he will not focus on the meal. In fact, for various clinical conditions, such as incontinence, bladder catheter or prostatitis, the patient can constantly feel the urge to urinate. In these cases, the patient usually does not remember that he is wearing a diaper. It is therefore possible, as an exception, to have the patient eat while sitting on the toilet, under the strict supervision of a caregiver. One behavior of Alzheimer's type dementias is non-stop walking. The elderly patient, in this case called wandering, will walk aimlessly, and without ever stopping. Patients of this type can refuse food because they do not want to interrupt their walk, and this criticality also occurs when they are in a wheelchair. To solve the problem, the caregiver must administer food to the patient while he is on the move. The elderly can refuse food because they are afraid of suffocating. This behavior occurs especially when, in the past, the patient actually had difficulty swallowing. The essential intervention is that of the psychologist. By applying a cognitive and behavioral approach, the psychologist will explain to the patient that his fear of dying can still happen, even if he does not eat. The speech therapist, however, will evaluate the right consistency of the food to prevent complications and put the patient in a safe condition. 4.3 Causes of depression and solutions. The elderly patient may be sad because he misses his home. This behavior usually occurs upon entering the nursing home. Refusal of food is the manifestation of this depression. It is therefore recommended to build an environment with the elderly that will become familiar, in which the subject can feel at home. The elderly patient may become depressed because he has lost self-esteem. He is mortified because he is fed, and therefore he feels useless. He feels he has lost his freedom. In these cases, the physiotherapist will work with the elderly, rehabilitating autonomy. As the patient recovers his skills, he will be more inclined to eat unaided, and to accept food. The elderly may also have pathological depression. Senility is, in fact, a risk factor for depression. Even stressful events, such as the death of relatives and friends, or loneliness, can make the patient sad and unable to feel pleasure. In these cases, the solution consists in drug therapy and in conversations with the psychologist. Refusal of food can also be a form of suicide, which the patient chooses to hasten his death. This cause should never be taken for granted, and must be the last hypothesis considered, once all the others have been excluded. As in the previous case, the solution consists in drug therapy, and in conversations with the psychologist. 4.4 Causes deriving from a psychiatric dimension, and solutions. It should not be ruled out that even the elderly patient may have anorexia nervosa. In these cases, the eating disorder, which manifests itself with the refusal of food, is linked to the patient's poor acceptance of his own body. The elderly can interpret their fast as the only event they can control, at a time when they are no longer free to plan their life. He will have to be rehabilitated, exactly as if he were a young anorexic, that is, with psychotherapy and a drug plan. The elderly person may have been, before admission, an alcoholic or a drug addict, or he may have become addicted to a drug, which is taken from him. The refusal of food, in these cases, is the manifestation of a withdrawal crisis. As in previous cases, the health team will have to rehabilitate the patient, with psychotherapy and medicines, in a detoxification plan. The elderly can refuse food because they report feeling a lump in the throat. The patient describes his difficulty in swallowing, saying that food cannot go down to the stomach. The speech therapist, doctor and nurse will have to assess whether the patient has a real swallowing disorder, if he suffers from side effects of the therapy, or if the esophagus is crushed, by the thyroid, or by masses. If none of these criticalities are found, the feeling of a lump in the throat is to be interpreted as a manifestation of depression, which will be treated with drugs and psychotherapy. Patients who have artificial nutrition, that is, who do not eat with their mouth, can also vomit. It is amazing that food can be refused even by patients who cannot eat. First of all, the doctor will investigate if there is a pathology, or a side effect of the therapy, that causes nausea. In the absence of this, vomiting is a form of anxiety and depression, as in the previous case. The problem will therefore have to be solved with an antidepressant drug therapy. 5.1. An efficacy statistic between method and pharmacology. I.R.M.I.E is an acronym, born in Italy in 2018, after 4 years of research. In the original language, it means investigation into the refusal of food in the institutionalized elderly. I.R.M.I.E it is the synthesis of the causes of lack of appetite, and of the hypothetical solutions, which have been described up to now. This pretest, or empirical method, has been applied, in the last 3 years, in over 20 rest homes in the province of Venice. The result was an 80% reduction in deaths in cases of refusal of food. 4 out of 5 patients were rehabilitated, thanks to the timeliness of the teams, who were able to identify the problem immediately, and start a healthcare pathway. Even more interesting is the analysis of 20% of patients who did not benefit from this method. Half of these patients had episodes of bloody vomiting during treatment. This event suggests that the patients had pain, or degenerative diseases, at the level of the digestive system, and therefore that their refusal of food resulted from more serious problems, compared to a real choice not to eat. The other half of the patients, that is 10% of the cases of elderly people who refuse food, died without a cause being identified. This suggests that hunger neurons have also been affected by the disease due to dementia and cognitive impairment. The patient, who has no short-term memory, cannot remember that he has not eaten, and it is not possible to explain to him that, by doing so, he risks dying. Injury to the hunger neurons results in the patient feeling no pleasure in food. He does not even feel appetite, nor sense of hunger, nor does he look for food, and neither is he satisfied in eating. The subjects of this type, who are 10% of the population studied, believe that eating is a useless waste of energy. 5.2. The new generation neuro-biological hypotheses. Research is studying a solution to create a sense of hunger in those individuals who do not feel appetite, since hunger neurons are supposed to have been compromised. At the moment, there are no drugs that stimulate appetite that have been tested in this type of patients, belonging to the elderly population. Pharmacological stimulation of hunger can be a side effect of some antidepressants, which have been given abundantly in nursing homes. However, it is not possible to study an effective correlation between medicine and fasting, as these drugs have been created and tested on a younger population and with an intact nervous system. A hypothesis of a pharmacological solution to the problem being analyzed is studied in THC, which is one of the excipients of the cannabinoid. The hypothesis that some research groups support is that the effect of this substance is to trigger intense hunger. In other words, what in jargon is called a munchies is an artificial appetite, involuntary from the commands of our body. The big question, relating to the effectiveness of this type of these drugs, lies in neurology and neurobiology. In fact, this solution would have no benefit if the drug were to stimulate the neurons of pleasure, because that site is already compromised, and the effect of the medicine would fall into a black hole. On the other hand, the hypothesis that the drug can stimulate regions of the cerebral cortex, which usually do not have the role of causing hunger, but would obtain the same effect thanks to the molecule studied, is more optimistic. Only the future will be able to reveal to us if the refusal of food in the institutionalized elderly will be a problem finally defeated, thanks to the synergy between the method, described here, and a new pharmacological approach.